do an overview in a fairly rapid manner today to be respectful of your time. For those of you who've missed it, today is April 15th. It is tax day. We just give you a little update on the timeline. The DSRIP Year 1 officially began on April 1st, 2 weeks ago. So we are officially on the clock, as it were, and we have begun to implement the implementation plan, if you will, which is due on the 1st of May. So could you advance the slides, please, Brenda? So here you can see the implementation plan due on May 1st. Let me say also, and this is very important, even though DSRIP Year 1 commenced on April 1st, we have not yet received any indication at all from New York State Department of Health as to what our maximum potential valuation might be. If those of you on the Medicaid listserv will have seen earlier this week that the DOH promulgated a new timeline, and they are now promising that we'll in fact all receive our maximum potential valuations sometime next Tuesday, April 21st. However, they have set deadlines in the past that for one reason or another they have been unable to meet. And so obviously things are still being worked out in detail between the state and CMS. And I will tell you, speaking for our PPS, we have no idea what is going on. So we hope, receive evaluation. Everybody will have access to all of that information on the public website, more or less simultaneous with our receiving any award notification. So we are still looking forward to an award that will enable us to implement all of our DSRIP projects, and that will enable us to further deepen our partnerships with each and every one of you. So we are hard at work on the implementation plan, which will be due to the state on May 1st. Now, the implementation plan is due, but then our very first quarterly report, which covers April, May, and June, it will be due July 31st to the state. Is that correct, Deborah? Mm-hmm. Yeah. And you can see on the timelines here, we are literally working at breakneck speed. We'll be counting on our partners to help us to implement these very aggressive timelines that have been established by the state. We are going to be beginning to count towards our metrics right now. And I'm going to let Dr. Deborah Viola speak in a little more detail about the implementation plan process and where we're at. So I want to thank everybody in advance for your partnership and your collaboration. And you're going to be hearing more about how that's all going to flow a little later on in this webinar. So, Deborah.
Thank you. Next slide, Brenda, please. So currently, as June indicated, we're responsible for the implementation plan. This takes us forward from what we submitted December 22nd, where we identified and justified through our community needs assessment and with working with all of you, the 11 projects that we hope to undertake as a DSRIP PPS. When had to go back to what we submitted end of December and start formulating the individual strategies and steps, achieve metrics and deliverables and requirements as outlined by the state. The action plan structure is actually, I'm almost thinking more demanding than what we had to do December 22nd. There are 11 sections up front that cover anything to do with governance, financial sustainability, cultural competency through performance reporting, as the slide shows. And there is a general project implementation section, which really takes these individual components and brings them together, and basically allows us to suggest how all of these will work in concert. They're not individual sections, but how all of these will work in concert to support and influence project rollout and implementation. And then for the 11 projects, there are 11 individual project sections. Within each of these sections, we're required to submit detailed steps by quarter, and alluded to those quarterly reports. The independent assessor will ask us to submit that we've achieved each of these steps or targets. We're also responsible for detailing our IT system and processes, and these will support these sections each of our projects to ensure that we are managing population health and engaging practitioners and addressing workforce strategy and everything that really has to do with infrastructure and sustainability longer term. We've been aided by KPMG, who was hired by the state to help each PPS as we draft these plans, and we've gotten some really good feedback from them. And you can see our remaining tasks. We anticipate our final evaluation so that we can finalize our budget and funds flow and financial sustainability sections. We are required, of course, to have our implementation plan approved by the board of our executive committee. We submit that May 1st, and then we may have to go through another round depending on feedback that we get from the independent assessor, which we're hoping to have by June 1st. So to give you a sense of what some of these tasks are about, I'm going to ask Brenda to advance another slide and give you a look at what we may be doing and what you may be doing with us, quite frankly, in DSRIP Year 1. So we have some groups that we are convening, for example, the Hudson Region DSRIP Clinical Council, and Jesse will speak a little bit more about this group later. It's our way of working and continuing to work with the other PPSs in the region to assure uniformity, our approach to projects that are common to all of us. Same holds true for the Hudson Region DSRIP Public Health Council, and here we are working not only with the PPSs, but with our local departments of health, mental health, and social services to address public health issues and projects. In fact, our first work group has been formed, the tobacco cessation work group. We are communicating through webinars, as we are this morning, and conference calls. Some of these are with some of you, I would say, based on a project need or a skill set, and some of these are more broadly conducted, like today's PAC. And when we talk a little bit more about the Clinical Council, we'll also talk a little bit about our quality committees and some work groups that you may be interested in participating with. Why don't you actually speak about this now?
Okay, great. Thank you, Deborah. You want to move to the next slide? Great. So actually, the last PPS, the Hudson Region DSRIP Clinical Council, isn't on this slide. It would be an advisory capacity off to the side of the quality committee that's on this slide. So that is one of the committees that will be the council that will be forming jointly with the other PPSs. And if someone has a particular interest in serving in that role, please let me or Lauren Klein, whose email address is at the bottom of this slide, let us know. I want to talk a little bit about the quality committee and the project quality committees, because we are establishing the project quality committees now and looking for more participation. So some of you may remember from a previous PAC and then from the primary care webinars that we did, that we asked you to let us know about what your passion was, what you were really interested in, and several of you did respond, and we're in the process of reaching out to the people who indicated particular interest in particular projects to get them to participate on the committees, but I'm give you this other opportunity to let us know. So if you or someone in your organization is particularly interested in being part of one of these project committees, asthma, diabetes, cancer screening, hospital care transitions, behavioral health, the Health Home at Risk project, please let me know or send your name to Lauren Klein, whose email address is here. I want to also just talk a little bit about the PPS-wide Quality Committee. This is the committee that is required, the DSRIP process that will report to the exec through its steering committee. And we think that important that we have all stakeholders represented in the project, in the quality committee, and so we're going to ask every participating organization to nominate someone to participate on the quality committee. We anticipate that the committee will probably meet quarterly by webinar, and so we'll be having more details, but I would like to invite everyone to think about their organization would participate in the broad committee. But the day work of the different projects will come from the project quality committees that are listed here. And then Deborah wants to talk just a little bit more about the patient activation project and the committee that she wants to establish to help her with that.
That was, by the way, Jessie Sullivan, our medical director. I think I just kind of take it for granted. I'm known to Jessie. So no, and I should have handed it off a little bit better. So I'm going to make a shameless pitch for help with what's known as Project 11. Our responsibility to activate and engage our low and unutilized and uninsured in the region. And we've had some folks reach out to me interest in participating, and I think with some extraordinary knowledge about how to go out and engage some of populations that tend to be a little bit more challenging for us to affect that process with. Using PAM is going to be new for most of us. It's not a widely used instrument at all in New York State, and it's also an opportunity for us longer term, quite honestly, to do a little bit of research and have a better understanding of how any of the services that we are providing may actually impact patients' ability to self-manage and to build their confidence in how they address their health care needs. So it would be wonderful. I am also going to ask you to reach out to Lauren Klein if you have interest in working with me on this project. I'm trying to form a work group, an advisory council around this, and I'd like to start off with a few providers. Allow me to use the term to incubate this process. Meaning I would have to, of course, assure that we have the availability of the instrument. We're working with New York State now to negotiate the license costs and to get folks out and in this tool. And so we have a sense of if folks are getting through the 13 questions, ways to do this that encourage full completion of the instrument.
Could you describe what the PAM is?
Oh, okay.
I might not know.
So June's behind me. I'm not seeing her waving. Describe the PAM. So PAM is a patient activation measure. It was developed at the University of Oregon. It's actually a widely used survey in probably 42 states in the U.S. and globally. There are a series of questions that essentially ask people how they feel about their own health, managing their health, understanding if they have health care needs. The questions are rather straightforward, but I guess some folks could consider these intrusive, especially given their particular circumstance. And the state, with their negotiations with CMS, I suppose CMS was trying to encourage New York to participate and thought this would be a good way of getting to hard-to-reach populations, having a sense of perhaps what their needs are, being able to engage them in the ways to get them into services and supports. We also have some ideas about how to do that, and we have another software tool that we're looking at, Healthify, that actually gets a little bit more information from people, but in a useful way that can direct them to a particular service and allow them to rate it like a Zagat, and there's been huge success with having folks energized around that, and that may be a nice way for us to also assure we have completion of PAM and that we have information on a subset of people that we can follow up with the PAM, because that's also required in this project. So this requires a huge field team across our region, and we're encouraging our providers and community-based organizations and local governmental units to come on board. And again, we'll provide the training, the tool, and assure that we're a resource so that we can reach these individuals. So thanks, Jessie, for allowing me that time. I think I'm switching over to Peg Moran to talk about the MSA a little bit.
Okay. Good morning. So I just wanted to give you an update on the Master Services Agreement. Your organizations all should have received a draft from us. It was out on March 13th. on the initial feedback we got from all of you, and mean that this could feel a little daunting to some providers, we had a webinar on March 24th where ourselves and Manad and West Medical Center's attorneys tried to clarify what the intent is, what some of the attachments meant. At the same time, we asked that we receive written comments on the agreement so that we could really look at those and really glean from those what are the issues and things that we need to address. So on April 24th, there will be another webinar to talk about that, what were the comments we received, what are we going to incorporate, and then after that, we will be finalizing the Master Services Agreement and then begin rolling out with the providers the execution of that agreement between Westchester Medical Center, RHI, and the participants. And after that, we're going to be developing and reviewing our project schedules and deliverables. Those of you who met with us on certain projects know that some projects have 12, 13, 14 deliverables. So there's some things we need to do, some things providers need to do. So we will be sitting down and talking with all of you or through webinars on what those projects are, how we can all work together.
May I just say a
sure,
quick interjection here? This is June Keenan. What we want people to understand about the MSA is that the MSA represents an agreement to the way that we propose governing the PPS. Each individual provider and participant will be negotiating directly with us the particulars of their participation. So we will not be discussing resources or deliverables by project in the MSA. It is truly an agreement among the parties to abide by the rules of governance that the Executive Committee has approved. So you are not committing resources and you're not committing to any deliverables by signing the MSA, and I just wanted to emphasize that. The MSA will be signed by all parties. Anybody who wants to participate in the incentive portion of the DSRIP program must sign the MSA, but the specifics of everybody's participation will be worked out one-on-one with each participant based on the projects that they are going to participate in with us and the specific deliverables we will be asking for and the resources that we will be deploying for each participant. So I just wanted to make that clarification, because if you choose not to negotiate a schedule, having signed the MSA will not obligate you to do anything. So thanks, Peg, for letting me clarify that.
Thank you, June. Brett, could you go to the next? We also need to undertake a variety of assessments. That's part of the project implementation required from DOH. So the first one is financial sustainability. And many of you responded to a request we had in November where we were asked to collect financial data from all of our potential participants, and so that we could review that and actually put that in our application. About half of the organizations did submit things, about half didn't. We now may need to go out to those of you who didn't to collect that information, because that is something we do need to report back to DOH once May 1st starts. Just wanted to give you a heads up on that. Deborah's going to talk about cultural competence.
So thanks. Just a point on the slide, list here actually become examples of those steps that I talked about earlier when we showed you the slide that covered the implementation plan structure in each of the sections. So you can imagine how many there are of these, because within any quarter, these could be maybe 2 of 6 steps for a metric or deliverable per quarter. But what we tried to do here was boil down to our most integral task that we need to do over the next several months. And so as paired to financial sustainability, I'm reminded that a lot of what you see under even practitioner engagement about prototype specialties, even within workforce, we had sent out several surveys to prepare our project plans for December 22nd. And you may be wondering why we haven't revisited you yet. And in part, we will have to resurvey because now we know what the projects are. But the step is really getting the sense of what people will be doing with respect to the projects and thinking about what capacities and capabilities are that we need to have to achieve the metrics and milestones and deliverables. So we're going to roll this process out a little more slowly than some of you may have thought, which is probably a nice thing. But when we do ask these questions, it will be because what's known as the assessments, the current state assessments, are really critical to success for the project and are a requirement of the implementation plan schedule. And almost in all cases, they need to be completed by the end of DSRIP year 1. So when we're out there asking, we'll probably be there asking and kind of running with it at the same time. The reason I want to highlight cultural competency and health literacy does drive back a little bit to Project 11 or our engagement project. And so it's going to be very important for all of our projects as we start to implement them to be aware and sensitive to local differences within the population groups that we'll be reaching out to. I think this is particularly true of Project 11. The patient activation measure is available in many different languages, but it's a little bit more than having language friendliness, as we know, in making any of these things successful. So what I'm also hoping to do is that within the region, you guys know each other far than we ever could. There's some folks that I should be reaching out to so that they can help us be these champions within your communities, and it may be your own organization. So again, we'll give some information, contact information when we close, but you can always reach out to Lauren Klein or myself if you have an interest in participating or being one of these champions in our region. I asked Jesse to address specifically these clinical projects. Now we've talked a lot about our engagement. Jesse?
Great, thanks, Deb. Let's go to the next slide. Okay, so most of the projects, not all of the projects, but most of the projects require most of the work to be done by primary care. So the whole DSRIP project, primary care is really central to the success of the entire DSRIP enterprise. And to that point, we have already been out resurveying primary care participants to get a little bit more detail about all the locations and how many practitioners are at each location and what some of the services that are offered are as they relate to our project. And we are about 85% done with that survey. If you do provide primary care services and you have not heard from us, please tell Melissa Thomas Belmar or contact her by email because it's really important that we get that information for every primary care site. And really this that we've been doing, this initial survey, is a preliminary survey to allow us to prepare for a more in-depth assessment of each primary care practice around readiness for health information technology and for the implementation of patient-centered medical home, which is a central project to the development of an integrated delivery system and is going to be a big part of the whole DSRIP effort. So, so you'll be hearing more from us for a more in-depth assessment of IT and readiness for patient-centered medical home, but it's really important that we have on our radar who all the primary care practitioners are and where they're located. So please get in touch with us if you haven't heard from us. We had two webinars for primary care practices, And if you are a primary care site and you weren't able to participate in one of those webinars, if you could please let either Melissa Thomas Belmar or Lauren Klein know, her emails come again, let me know. We'll look and see if there's enough people. We will do a couple of more primary care webinars. The rest of this slide just kind of talks about each of the, or not every project, but the components of the projects that are very heavily dependent on primary care, and I'll just read through them quickly. So cancer screening, patient-centered medical home, a big project, health home at risk, probably isn't self-explanatory. Let me just take a second to say that this is the project that we're going to use to do a lot of the other project work. And this is not home health and it's not patient-centered medical home. Health home is a program of, is a care management benefit for Medicaid beneficiaries. It is being delivered now for the most part through agencies that are connected with behavioral health providers. And through the DSRIP project, we are going to link health homes more closely with primary care and expand the management services to Medicaid beneficiaries who aren't now covered by health home services. So this is a project that we're going to use to implement a lot of the other work that we need to do. We're doing a very important care transition, care coordination project to hospital readmissions. Obviously, that involves hospitals, but more importantly involves the primary care that has to pick up the care when the patient leaves the hospital. Diabetes, tobacco cessation, of behavioral health services with primary care. If you are a primary care site and you have an interest in participating in adding behavioral health services to your site and you have not already been in touch with us about that, please let us know. And the last one is the patient activation measure that Deborah's been talking about. So, please just end with a plug that, again, please let us know if you have particular interest in participating in one of these quality committees as we're beginning to organize the projects in more detail. And then I'm going to hand it back to Peg Moran, who's going to talk about the capital.
We need to talk about capital because many of you may know that DOH, as a result of the state budget, has reissued the request for applications and expanded the pool, which is good news, to $1.2 billion. Just a little backtrack. In November 2014, DOH issued a RFA asking providers, any kind of provider who wanted to request capital dollars, that they needed to do that, they needed to follow the DOH application process, and that they needed to send it to the PPS, the one they were most affiliated with, where it would be ranked, prioritized, and sent to DOH. So, little echo.
Wow, there you go. Are you like really
Right. Would people please make sure that you have your mute on your phone?
I think you had it. Okay, good. Thank you. As a result, and we are sending
Oh, no. So isn't it so well?
further reasonable?
Yes, I'm trying to fix it. It's coming from one line. Just give me 1 second.
Oh, thank you.
Okay, good.
Oh, so as a result, DOH just last week said, okay, everybody, now you have to resubmit all of the applications. And what they did is they opened the door for providers to revise their applications, maybe something changed, maybe a location changed, so they were giving them that opportunity, as well as they opened it up to providers who had not previously submitted an application. So on this slide, what you'll see on the right-hand side is the DOH requirements of us and of the providers, how everything needs to be submitted to DOH through the PPS by May 6th. The good news is the application forms, none of the attachments changed. So if you have no change in your application, it should be a very smooth process. If you turn to the next page, the next slide, 16, here are the detailed steps that providers will need to go through. And again, we had 25 applications, and all 25 participants will need to resubmit their application based on one of the 3 categories. And in each case, you'll see this, you do need to put the new RFA number on it. So that is, again, these are the state rules, and we are just following those rules because we clearly want our providers to get the funding they need in order to do these projects, many of which are completely aligned and critically important to the success of our DSRIP. So just to go through the 3 scenarios, the first one is if you have no change, you just resubmit your same application to us, and there is a letter of attestation that the state developed DOH where you have to sign and say, yes, there is no change from my original application. So let's say A. Name signatory, and this is all detailed in the correspondence we're sent out to you, but it has to be the same person that had signed before. The second option is for participants that may want to modify their application. Again, that they would resend that to us, and there is going to be a form attached where they have to explain or justify what the change is. DOH is particularly looking if people want, a provider wants to increase the funding of their application, they will see a justification as to why you now need more funding for that. And then the third is for new applications. So anyone who is a new applicant, you're not familiar, you need to go to the DOH website. It's on our letter, it's on the prior page, and it's quite a detailed application process. If someone is going to submit a new one, I just really suggest you start working on it now because it is quite a bit of work. So the next steps for us is that we are asking participants to email us all of your changes based on one of the 3 categories you fall into by Friday, March 24th. The last time we did this, it was quite a bit of work getting all of the attachments, the architectural drawings. It's quite a bit of transmission work to DOH and getting the verification from them that they actually received it. There's work on our end, and we need to make sure that we successfully transmit your application. So that's why we came up with that date. Again, you'll see this letter coming out today. If you have any questions, please get back to us, but we're trying to make it really as simple as possible while following DOH's rules. Okay. So Brenda, go to the next one, partner participation. So what we wanted to do is just give you, this is really just a sample of all the meetings and types of activities we've all been involved in. Some people say to us, well, I haven't heard, what are you doing on this? And this, again, is just a way of communicating to you just some of what we've been engaged with, whether we're meeting with counties, our local governmental meetings, doing the PCP webinars, lots of primary care meetings, at FQHCs. So this, again, is just a sample of what we've been doing. If you could go to the next one. Here we wanted to just give a sense of just some of, but this is totally not all of them, but just give you a sample again of the kinds of work we're doing. And so much of what we do, and I know you know this, is really on the phone. We have more conference calls, meetings. It is how to get out to 8 counties and to do all the things we want to do. So we wanted to give you some sense of activity if you haven't yet heard from us.
Thanks. So actually reminded that this year one began April 1st. And so a lot of this activity we're also responsible for tracking and recording. So that's the attendee list, meeting minutes, the presentations. This really is looking over our shoulder to assure the level of participation that we need to be successful. So I would like to start the upcoming meeting slides. Actually, if you go back one slide, Brenda, just take a moment. Some of the meetings, and we talked about this earlier, are specific to provider type group or specific to need for particular projects. We do have some opportunities where we open this up to the full PAC, and this Hudson DSRIP Public Health Council that we spoke about earlier. We have our first meeting focused on tobacco cessation. It is tomorrow. We had sent this out in our newsletter. I'm sure many of you did not see it, and I apologize, but this is just going to be our first meeting. You can still attend on site here tomorrow or dial in. We have a place on the mix. We have involvement from organizations like American Lung Association, the Asthma Coalition, as well as our other PPSs. This meeting being run jointly with Amanda Parsons at Montefiore, as well as colleagues at Reissuance Health Center. And we have reached out to the Department's Health as well. In addition, if you will, this massive public health messaging aimed at reducing tobacco use, specifically in some more challenging groups to work with, those with low socioeconomic status. We see some increase among teens and on college campuses and with the behavioral health group. So now, if you fast forward to that list of contacts slide, thank you, and the next one, it's probably good for me to kind of regroup here. We've asked you to think about participating on our project quality committees and work groups, and I want to re-emphasize this, and Lauren Klein would be the point person for basically all of our projects, and she'll know who to reach out to here. As Peg reviewed with you, we have another MSA webinar, April 24th, so please reach out to Peg if you are interested in participating in that or need more information. And yes, reach out directly to me so that I can get you hooked up if you're able to come to our site tomorrow or call in and have an interest in helping us develop the tobacco cessation group. And finally, if you're unsure of who to contact, have questions that surface when we hang up today, have interest, have information you want to share, please do so at our CRHI website. And we have someone monitors that Monday to Friday during the workday, and I believe our success at getting back is pretty darn good. I think we're at 100%, and we tried for a 24-hour, but probably give us a couple more days. I'm getting looks now, so give us a couple more days. And then on our last page, of course, is our team, and thank you for this opportunity. I guess we'll open it up to questions. Brenda has that for us.
We would love to open the lines for verbal questions, but we have almost 150 people on, and as you saw, when one line opens, we get a lot of feedback. So we're going to need to use the chat function to manage Q&A today. So if you see on the right-hand side of your screen, you can send a question to Keir Wallace, the host, you can see name at the top. I'm not Kier, but I'm using Kier's account, so you can see that name up at the top, and we'll read out the questions. Some of the questions that have come in so far relate to whether these slides will be made available. They will. They'll be made available through the CHR website pretty soon following this webinar. In addition, folks have asked about past webinars, including the primary care physician webinars, and whether they're available to listen to, so folks can go and listen to on their own time. All of the webinars are archived on the website, as are a lot of PowerPoint materials. So definitely direct everyone there. Deborah, question about the tobacco cessation meeting tomorrow, and if people want to get involved with that, what it is and how they get involved with that.
So I do have an 877 call-in number that I can send you if you send me an email and that you're interested in participating. It's from 11:30 to 1. And so you can come in at any time during that point if you don't have the full block available. In fact, I can send you an agenda, as well. And that's Viola D at WCMC.com, but 11:30 to 1. If you plan on coming on site, please let me know so that I assure seating room. But we do have the 877 number.
I just wanted to say that we were not able to record the primary care webinar. So you're right that the deck is on the website, but we weren't able to record. So if people find that they, just from looking at the deck, that they, that's not enough, as I said, if people let me know, we'll set up another one.
Folks have asked about times for the MSA webinar and other meetings that you've mentioned. Mario Smith, the Senior Communications Manager at the Center, has just reminded me that there is a partner portal page on the website, and they keep it updated with regular meeting dates and correspondence and every way to register for things. So I'm just going to put that in the chat box for everybody now. It's at crhi-ny.org, and that's the easiest way to get that information. The MSA, the Master Services Agreement webinar on April 24th is from 11:30 to 1:30. It's a little bit of a longer webinar because we have a lot of feedback to go through.
Bernice will be participating.
June, I've gotten a couple of comments that people said they don't think that they received the Master Services Agreement draft back in March, and how do they get a copy of it?
Just some people, all the organizations that are partners and who have attested have received the MSA. In some cases, we did receive calls because the MSA went to somebody other than who thought they should have gotten it. So if, in fact, you have not received the MSA, just your organization. Yeah, it's important to make sure that it's your organization that has not received it. If you have not, please contact Peg Moran and get you one. But we do know that every
went to the CEOs.
Yes, it went to CEOs.
Or whoever sent in the attestation to be part of our network. So that's who we sent it to, who has the authority to sign it. So we double-checked, and that's who it went to. So just in with your organization in terms of their receipt of it.
And when will the updated Master Services Agreement be sent out, and do they download documents? Will we send them?
Master Services Agreement will be resent out after the changes have been made subsequent to the webinar on the 24th. I guess it depends on how extensive the changes are going to be. Everybody will see the changes that were requested, and then everybody will see in a matrix the response that we've made to those changes. So it'll be turnaround time, but when we send out the final version of the MSA, it will not be subject to revision at that point, and so people will either sign it or not.
And just to clarify, you will send those documents. There are a lot of attachments. Those will be sent to every organization. They won't be to go somewhere and download everything. Correct?
So I think we would send them out just as we did before. They were emailed out to everyone, and we would do the exact same process.
Okay, this is a question. Has there been any indication on when the capital fund awards will be announced after the resubmission?
Well, prior to this latest opening up of the RFA, we're going to have some intelligence by June as to what the health department is going to recommend. We would maintain that we still need to know by June because some of our DSRIP projects, like the medical villages, for example, are highly dependent on receipt of capital funding. So hopefully they will stay with the June deadline, but more than that I cannot say.
Any other last call for questions? I think, as I said, these slides, like the other ones, will be posted on the website. And June, I will turn over to you.
Well, I'd just like to thank everybody for your attention and participation today. Again, if you have specific questions, you have our contact numbers. We're very much looking forward to moving ahead with implementation, and we're very much looking forward to receiving some indication from the state as to what our maximum available valuation will be. I'd just like to remind people when they see maximum potential valuation, it means that the valuation has to be earned. It's not going to be granted to us as of right. It is all going to be earned after the very first payment. Everything is subject to meeting deliverables, so everybody needs to know that. So we will all have a hand to play in how we obtain the maximum potential valuation. So look forward to getting good news on that early next week and moving along with all of you. And thank you very much again, and we'll be in touch, and will you guys be in touch as well. So with that, I'm going to close out the webinar. Thank you, Brenda, and thank you, everybody, for participating.